Все. Hello, dear colleagues, assalamu alaikum. Сәлеметсіздер ма? Мен Mynzhylky Салауовичпін, қорықпай жата беріңіз, жақсы ма? Berdikhojayev, Mynzhylky Салауовичпін. Patient is under local anesthesia. My name is Mynzhylky Berdikhojayev. My assistant Ahmed Mohammed Khan. This is in the neurosurgical department of the National Hospital of the Medical Center of the Presidential Affairs Administration of the Republic of Kazakhstan. Дұрыс айттым ғой, да, Ahmed? It's a long naming. It's just a presidential national hospital in Almaty. And operating nurse is Bakht. Anesthesiology nurse is Janna. Video support today presented with Video Company, and Roman Povyshev is a video engineer of the company. Evgeny Grishayev today at the different event. No, трехходовой экран кирка. Evgeny at the different event. That's why Roman is in the operating room. Patient has a meningioma, nearly 3 centimeters. Так, ну, тоже контрастно. Has a meningioma. It's in the right temporal region, and clinically presented by the seizures. That's why the MR angiography diagnostic was done, and on MR angiography we need a 3-way stopcock, but Bakht is looking for. And now is the period when we are waiting for the tenders, and a lot of material is not in the department. It will be like this for another 1 month or 1.5. It's a specific of governmental system. I'm still inflating the balloon now. Now contrast is key. Okay. Yes, this is a Scepter Mini, and this is full contrast. 1 cc syringe from the Menox box, and now we will deflate the Mini. It will take some time. Okay, the stopcock is ready. Okay. Like this. Yes, the contrast should be 100%. The balloon is too small, that's why the visibility of the balloon is a little bit worse than you can expect. Okay. It's a Menox syringe with the syringes from Squid or Onyx. It's less like this, but the Menox syringes is like this. Okay. Now the balloon is still inflated. Because of full contrast, balloon deflates slowly. Okay, now I think it's Deflate, yes, deflates. Shai Ahmed took 7 French short introducer sheaths in a patient lady, right? Man ba? Man ba, lady ma? Lady. In a lady, 58 years old. Yes, in Kazakhstan, ladies are mean average of life expectation is 78 years. She has another 20 years. The mean age of Kazakh people is 75 years last year. This year might be longer, but not so significantly, I think, because nothing was done. Huh? Shai Ahmed. So, nothing in public health care was done to wait 80 years.
That's something trying to do.
Yes, it's all the time like this, but yes, Shai Ahmed now in common carotid. Okay, let's see the images. Бақыт экранды бір 15 сантиметр аяғына қарай жылжытасаңызшы. It's Kazakh language, yeah? Okay, this is a fubuki, 7 French, angled one. Экран 15 сантиметр аяғына қарай. The aortic arch is normal. Пойдет. Now we can see the blush of the tumor here. It's a middle meningeal territory. There is no A1 segment. It's a PCOM, PCA territory. Yes. The ICA territory, MCA and PCA is not supplying the tumor. This is a avascular zone, which is meningioma. It's a good sign, no? It's a sign that, but there is a venous delay. We discussed with Michihiro Tanaka. If there is a venous congestion, then the brain would be edematous and it might be symptoms. Now it's common carotid, external carotid, and the meningeal artery is supplying the tumor. I think this branch is going directly to the tumor. The small branch may be this one, and this one also goes with the collaterals. And also for the local anesthesia, we will bring the Scepter Mini here. We took the Scepter Mini. We have also Sonic, but for the Sonic we need to place some coils. That's why we decided to take a Scepter Mini. Okay, it's a meningioma. Right side, the ECOM is working, everything is okay. PCA territory is okay. Right vertebral is okay. It's so-called 4-vessel angiography. Yeah? Okay, let's start. Squid, okay. Squid tonic. Пока полметра. Пока полметра. Yes, we will prepare squid 12. As usual, the screen is not properly. The problem is we see the Philips engineers when the real problem is coming, but when there is a small problems, there is no Philips engineers. We should call them, and there is a problem of the service agreement. Oh, that's why the large focus defect is still there. It's remaining since October. We can see all videos, and this problem is on the big screen, large focus use, small focus defect. It's since October, and I think the hospital administrations forgot about this problem, and today we need to sign the documents about this problem and send it to the department involved for the organization of the medical equipment supply. Yes, this is Fubuki. It's a little bit rotation, and then instrument is in place. Yes, it might cause a little bit spasm, but it's okay. For external carotid system is okay. The Scepter Mini we took with the regular stopcock. The flow switch is not recommended because with flow switch stopcock normal. With slow switch it's possible to inflate the balloon unexpectedly and rupture the vessel. That's why jak się fakam и дали дека им дай да хода сосна. The wire is coming. It's a Chikai 8. Yes, now we're in the territory of meningeal. We'll take it out. Yes, it could be a mistake, that's why I need to close the three-way stopcock. There are two syringes, and we may cause the mistake, that's why it's better to close it. Like this. Yes, there are 2-3 branches going to the territory. I think we can catheterize one of them, yeah? With no problem. The middle one is a little bit bigger one. Also the lower branch is going there. It was discussion about the microsurgery. We will see the clinical symptoms, if it would be controlled by the medication. Usually it's enough. The simple embolization without microsurgery could be enough. And enough is enough. Huh? This branch is more friendly, but I hope the Scepter Mini can go there, because the lumen, yes, it went in the branch. Okay. It's as much as possible. Huh? Okay. We're trying to inflate it. We may rupture the artery. Yeah? Okay. Let's see. It sounds also we can place one more microcatheter in the different territory. Yes, that's nice. Then we can take all meningioma. Now I will ask for the lidocaine. I a little bit inflated this scepter mini, and I hope it will stay like this. Lidocaine. Okay, lidocaine. Obsessor. Is squid tonic. Yes, we will work with the squid 12. Now I'm injecting 2% 4 cc lidocaine, which is 80 milligram. Yes, it's possible to do also with the sonic, but usually there is a reflux. And the squid and the meso injection is a little bit painful. But just after the stopping the injection, pain is releasing. It's interesting, no? Okay. Glue. Okay. We'll put the angiogram on the review screen. It's like this, and this is whole territory. Yes, we can take from the... Yeah, Dexa unique milligrams is... we asked for the Lornoxicam. It's from the family of oxycams. And now we asked for dexamethasone, which is very important because of the dimethyl sulfoxide. Now we are taking the territory of meningioma. Also there is a collaterals coming from another two branches. Yes, this is a branch from above, and it should be the branch from below. Okay, it could be a little bit painful. It's like a highway with the many branches coming. Yes, now there is a branch from below. We should occlude it. It's better to occlude it. We'll try to take it from the meningioma. Yeah? Okay. Yes, now we come from the meningioma to the skull base. Yes, it might be a little bit painful. I'm mostly orienting on the AP view. AP view is more informative than the lateral. I will inject a little bit more, a little bit more, a little bit more. Ah, it's something from the outside, huh? Но не сяхта поверхностная височница. Хорошо, поверхностная височница. It's a territory of superficial temporal artery. It's a transosseal. Stop. Some part of the meningioma is still alive because of the branch is alive. Huh? I think it's auricular artery, yeah? Заушная артерия, кажется. Retroauricular. Auricularis posterior. Okay. Rodmo? Rodmo? It's all outside, huh? It's look like all the outside. Yes, it's extracranial. And it's arterial supply from the extracranial to intracranial. It's feeding the aponeurosis, huh? And the temporal muscle. Yes, now we are mostly inside the meningioma, a little bit in the extracranial. We can wait a bit. And the meningeal branch is still alive, huh? Предыдущий ангиографен. Окей, Чурисл. Окей, Чурисл. Полный, Джожо. На весь экран. Yes, it's still alive, and that's why the small branches are still feeding the meningioma. It's more proximal. This branch is going to the meningioma. Yes, this branch. Okay, let's continue. Yes, septal mini works very nice, and now we are in the meningeal territory. Yes, it should be possible to penetrate from meningioma itself, intratumoral network. If it's possible, it's better, without feeling the outside this. Okay. Okay, свежеродно. It might be 1 centimeter of the meningioma is remaining from the temporal branch of the meningeal artery. It's on the base of the skull. Yes, it might be. Okay, let's see what we can do. Also we can pull a little bit the septal mini, and then yes, I know, I see. We should create a little bit reflex. The artery in the outside is too small. Now I deflated the balloon. If you can see, the balloon is deflated, and we'll try to bring it to the proximal territory. Okay. bring it a little bit proximal. Предыдущий ангион выжив. Вперед, вперед. Стоп. Okay. Okay, now it's better. We can inflate the septor mini here. It's a territory of branch, yeah? Okay, now mini is inflated. Yes, it's exactly there. We'll just take the remaining part from here.
Қазір кішкене шыдаңыз бол.
The distal part we took already, it was a small isolated part. Yes. And tomorrow we will do MR with contrast. Shaykh Met, okay? Tomorrow. To decide about the next step. I recommended to keep the patient under follow-up. Also the PhD work from Astana Presidential is now on the way. Islambeck is doing the PhD. He focused on comparing the endovascular and the radiosurgery results. I think it's comparable. For the radiosurgery, the limitation is 3 centimeter in size. For endovascular, we can take bigger one. And also the radiating the convex meningiomas, we can do all convex meningiomas, and also we can do skull base. Not all skull base meningiomas is suitable for the radiosurgery. Еще раз. We'll see. I will inject a little bit more. Yes, it's going to the both branches, mostly to the posterior branch.
Болт. Қимылдамаймыз.
Yes, we can inject a little bit more. I will wait. Yes, this territory is not penetrated by lidocaine, that's why it's a little bit painful, huh? Yes, the PhD work is better. Islambeck should publish, and also we agreed to join the meningioma trial started with Italian colleagues, Italian, Indian colleagues and German colleagues, maybe some other. Simon Pichila is the organizer. Okay, we'll see. Таны жүріп жатсыңдар ғой да, жинап.
Біз бөліп алғанбыз ғой, каждыйымыз. Но я свою часть сделал, кімдер жасап қойды, надо. Там бір-екі моменттер бар, которые непонятны.
It's Shaykh Ahmed, Abzal Jumabekov and Ravan Maratullah Айтели. Maksat Musabekov started to collect the data for the last 10 years, yeah? Last 10 years.
10 years, but...
The most of the embolization is started since COVID time. Maybe a little bit earlier. We started just to embolize and follow the patients. And we saw the dramatic shrinkage of the tumor without growing, mostly in parasagittal with involving the sinus. It's very okay. It's painful, I know. Okay.
Dealing both stance. Dealing both stance.
Okay. Now we can finish. Okay. We took the feeders and we also occluded the meningioma. Okay. The septum mini is out. It's a nice tool, huh? If you learn how to do it with the septum mini, it's a nice tool, but I'm still scared to use in intracranial. I'm waiting for the Aptura, liquid embolic from Spain, and Aptura is less sticky, and even with the bigger reflux it's possible to take out the microcatheter. Okay, everything is okay. The ICA territory is clear. Okay, let's do one more angio. Yes, meningioma was occluded. The ICA territory, MCA, PCA is clear. Okay. CT control. Қалайсыз? Сәл-сәл ауырған қояды қазір басылады. Азайып келе жатыр ғой. Ана ісіктің тамырларын толық бітедік. Ертең МРТ жасаймыз. Егер ісік полный қарайып кететін болса, басыңызды ашудың қажеті жоқ. Жарайды ма? Келісесіз ба? Или ашайық па? Жоқ. Жақсы. Ертең МРТ жасаймыз. Қазір жата тұрыңыз. Бір 5 минутта бітіреміз. Okay, patient doesn't want craniotomy. No, nobody wants. If it's possible to do without craniotomy, it's better. Without craniotomy. Кіттің ортаға шарасқа. Dear colleagues, the CT is ready. And now we can see the brain. Brain is clear. This is meningioma. And it's well penetrated. Okay. Tomorrow we will ask the radiology department to do MR with contrast, and then we can decide should we resect it or not. Usually they shrink and disappear. Okay, the next case is petroclival meningioma, more than 5 centimeters, growing in the cavernous sinus and the petroclival region in posterior fossa. We will do it under general anesthesia. That's why the next case will be in 30 to 40 minutes. Thank you for watching. See you in 40 minutes.